Good afternoon and welcome all. As Florence Nightingale Hospitals, we're really pleased to see you among us today. Today we are with Professor Dr. Gökmen Sevindik. Hello, Professor
Hello.
Doctor.
It's my great pleasure to be here and to be with our colleagues from all over Georgia and the other countries. Thank you.
Thank you so much. If you could introduce yourself to us.
For sure. I am Professor Gökmen Sevindik and I am 43 years old. I have finished my medical education at Hacettepe University, Ankara. And then I have obtained my internal medicine and hematology degrees from 9 Eylül University in Izmir. While I was a Hem Fellow, I had the opportunity to visit Mayo Clinic, Rochester, USA, and I had the opportunity to work with Shaji Kumar, who is a very well-known myeloma expert in the world. And during that time period, I had the chance to be in cooperation with BMT unit of Mayo Clinic and also lymphoma and leukemia services of Mayo Clinic. And then I have got back to Turkey and I have finished my obligatory service at Elazığ. And then I have moved to Istanbul and I worked at Medipol University for 6.5 years. And it's been a while. I'm working at Florence International Hospital Group and I am just now trying to serve the patients of Florence Group.
Thank you so much, Professor. Could you please give a brief overview about the topics we're going to discuss today?
Sure. As a hematologist, in Turkey, actually, the hematologist specialists are not taking care of solid organ malignancies. I am just seeing a lot of patients who are diagnosed with some benign blood disorders and also some malignant blood cancers. Actually, we can just divide the bulk of patients who are just visiting us into these two groups. A lot of patients are just being diagnosed with anemia or some abnormalities regarding leukocyte counts or thrombocyte counts and some benign disorders. And also we have a bunch of patients who are diagnosed with leukemias, lymphomas, and myelomas, and some other rare entities that we are just taking care of.
Okay, so I would like to start with the questions,
Sure.
If that's okay with you. What are the most common blood disorders?
Actually, the most common blood disorders, when we are just thinking about a worldwide incidence, is anemia. Actually, anemia is a kind of easily manageable disorder, but we have a lot of patients suffering from recurring iron deficiency anemias or some other kind of nutritional deficiencies. We can just put anemia at the top of the list, and then comes some abnormalities regarding thrombocyte counts and thrombocyte abnormalities like immune thrombocytopenia, some bleeding disorders like von Willebrand disease or deficiencies of von Willebrand factors, some congenital ones and some acquired ones. And then comes the leukocyte abnormalities like leukopenias or leukocytosis, both secondary to some other disorders and some primary ones that we're just taking care of. And then comes, unfortunately, the blood cancers. Regarding blood cancers, the most common one is lymphomas. Lymphomas comprises the 10th most common cancers regarding all cancers. And then comes multiple myeloma, and to some extent comes leukemias. We're just dividing leukemias into two major subgroups like acute leukemias and chronic leukemias. I can say that chronic leukemias are much higher regarding the incidence than acute leukemias, thankfully, because acute leukemias are just cumbersome to manage. But the least common ones are acute leukemias. And we have a lot of rare entities like some rare leukemia types, rare myeloma types, or rare plasma cell disorders. But up to an extent, we can just put anemias to the top of the list and the cancers to the down of the list.
Thank you so much. And how do blood disorders differ from blood cancers?
Actually, blood cancers are the disorders which have a unique feature that we are just calling them as neoplasia. They are clonal disorders. Actually, they are clonal disorders of both stem cells and some more mature cells. If we have a clonal abnormality that we can show with some genetic tests, we call that disorder as blood cancers. And we are just putting the leukemias, lymphomas, and myelomas into that burden, which we call blood cancers. But if there is nothing wrong with any clonality, then we can say that this is a blood disorder instead of a blood cancer, like anemias or some other benign hematological disorders like bleeding diaphysis or thrombophilia or the other ones.
Okay, and what are the general risk factors for developing blood disorders?
Oh, that's a good question. Actually, we have some common risk factors to develop blood cancer and some common risk factors to develop blood disorders. Actually, smoking should be one of those unfortunate risk factors. Actually, it's common in Turkey, and I can imagine that it's also common in some other countries. I can just put that at the top of the list. And with that, irradiation or some pesticides, unfortunately, it's really abused in the field of agriculture, and we are just relating those pesticides with some blood cancers, some specific blood cancers like multiple myeloma. I can say that these are general risk factors, but also obesity or extreme consumption of sugar and salt should also be underlined as a risk factor for both blood cancers and blood disorders.
Okay, thank you so much. If we can focus on blood cancers, what are the main types of blood cancers?
Sure. Actually, the most common one is lymphoma. And also we are dividing lymphoma into two subsets. One is Hodgkin's disease. Actually, we do not call that as a Hodgkin's lymphoma or Hodgkin's neoplasia. It's Hodgkin's disease. And also we have non-Hodgkin lymphomas. Non-Hodgkin lymphomas are 8 to 10 times more common than Hodgkin lymphoma. And then comes plasma cell disorders. Actually, the one which is common is multiple myeloma. It's just 1% of all cancers and 10% of all blood cancers. And then comes leukemias. As I told you before, we are just separating leukemias into acute forms, which has a clonal increased numbers of immature cells, and we are just dividing it to another subset called chronic leukemias, in which there is a clonal expansion of more mature cells. These are the common types of blood cancers, but we have some rare entities like POEMS syndrome, Castleman disorder, Langerhans histiocytosis, Erdheim-Chester disorder. We have a lot of rare entities which can be put in this group of disorders, but the common ones are lymphomas, multiple myeloma, and leukemias.
Okay, and how do leukemia, lymphoma, and myeloma differ?
Actually, they are differing in the cell of origin. Actually, lymphomas are originating from lymphocytes. That's why we call that entity as a lymphoma. Leukemias arise from immature myeloid or lymphoid progenitor cells. That's why we call those as leukemias. Leukemia actually means any unwanted increased number of cells which are not commonly observed at peripheral blood. And then we have myeloma. Actually, myeloma is a plasma cell disorder. It means that it's arising or originating from plasma cells, which are much mature forms of lymphocytes, B lymphocytes.
Okay, and what are the latest advancements in blood cancers?
Actually, I am happy to say that we have a lot of advancements in both diagnosis and treatment of blood disorders and blood cancers. If we focus on blood cancers, we have a new genetic era. With this new genetic and genomic era, and with the help of molecular tests that we are just commonly using nowadays, like next generation sequencing, we have much more clear idea about the origination of that clonality and also the prognosis and the diagnosis of those common blood cancers. Regarding treatments, thankfully, we are in a new era of non-chemotherapy era. We can just call that as non-chemotherapy era because before 1 or 2 decades, we were just using chemotherapies and corticosteroids in order to control these kind of disorders. But at that times, unfortunately, we were not able to offer a good survival to those patients who are diagnosed with blood cancers. But nowadays, we have immunotherapies, we have targeted agents, we have non-chemo options in even the worst subtypes of leukemias. With the advent of these kind of therapies, and also cellular therapies like bone marrow transplantation. Nowadays, we call that as hematopoietic stem cell transplantation, and also some other cellular therapies like CAR T-cell therapies. We are just really offering a good survival to even the patients who are diagnosed with leukemias. I can just give an example from multiple myeloma. Actually, in the 80s or 90s, the expected overall survival of a myeloma patient was just limited to 2 or 3 years. But nowadays, with the help of some proteasome inhibitors, immunomodulatory drugs, daratumumab, or other monoclonal antibodies, bispecific monoclonal antibodies, and CAR T-cell therapy, it is just rising up to 7 to 10 years. It's something really making us happy among the treatment of these kind of disorders. With the advent of those targeted agents and also immunotherapeutic agents and cellular therapies, nowadays we are generally having a good overall survival in the patients who are diagnosed with these unwanted blood cancers.
Thank you so much. That's really nice to hear. Okay, so I would like to ask you a few questions about diagnosis and treatment. How are blood disorders and cancers typically diagnosed?
Actually, all of the blood disorders or cancers are diagnosed among some specific signs and symptoms which could be attributable to that specific disorder. Actually, regarding the benign disorders, generally the patients are referred from family physicians or internal medicine specialists regarding the abnormalities of blood counts. Nowadays, it's really easy to access those blood tests, and they are generally used in family physician practice and internal medicine practice. And also we have some checkup policies. With that advent, generally patients are diagnosed before any kind of devastating symptom of that particular disorder. But actually, regarding blood cancers, patients are generally coming with the anemias or leukopenias or thrombocytopenias related with that specific kind of blood cancer. That's why they are generally presenting with symptoms like shortness of breath, dyspnea, or palpitation regarding anemia, or a long-standing infection regarding neutropenia or leukopenia, or some bleeding disorders should present with ecchymosis or bleeding, unwanted bleeding, let's say nosebleeds, gum bleeds, or some other skin bleeding. That's the commonest forms of symptoms or signs that are carrying patients to a visit with hematologist specialists. But actually, it's a big umbrella which should not be specified easily. But I can say that commonly they are just presenting with shortness of breath or palpitation or easy bruising or some kind of opportunistic infections that we are not commonly observing in healthy patients, and also long-standing infections.
I see. And what are the standard treatment options for various blood cancers?
Actually, regarding lymphomas, still we are just using some combined chemotherapy protocols in order to induce a good remission and even a cure up to some extent. Like in Hodgkin's lymphoma, we are using ABVD protocol, which combines 4 chemotherapies. And with that, we are just obtaining 80 to 85% of cure chance. But regarding non-Hodgkin's lymphomas, we are just adding some immunotherapies like monoclonal antibodies to those chemotherapy protocols. And if a patient somehow experiences a relapsing disorder, then comes the targeted agents and some other immunotherapies. Also, we can add radiotherapy regarding lymphomas, and up to some extent in some patients who are recurring after the first-line treatment, we can also use hematopoietic stem cell transplantation in order to obtain a good response. Regarding multiple myeloma, nowadays we are just abandoned chemotherapies. We have really good working targeted agents like proteasome inhibitors, immunomodulatory agents, and some other monoclonal antibodies like daratumumab. We are just combining 3 or 4 of those medications in order to induce a good response. After obtaining that response, we are generally proceeding with autologous hematopoietic stem cell transplantation in order to give a megadose of chemotherapy and to obtain a good progression-free remission. Regarding leukemias, we have some targeted agents that we can use in some particular types of those acute leukemias, like in Philadelphia, positive acute lymphoblastic leukemia. Nowadays, we are using some tyrosine kinase inhibitors, which are not chemotherapies. And also we have some monoclonal antibodies, bispecific T-cell engagers like blinatumomab, inotuzumab, in order to induce a good response in even at the first-line treatment and relapsing disorder of disorders of patients who are diagnosed with acute leukemias. Regarding chronic leukemias, we have again some therapeutic advance like small molecules, tyrosine kinase inhibitors, and with the help of those like ibrutinib, acalabrutinib, zanubrutinib in chronic lymphocytic leukemia, or some other tyrosine kinases in chronic myeloid leukemia like imatinib, dasatinib, nilotinib, or ponatinib, or bosutinib, even some other targeted agents like asciminib, we are just obtaining a good response and a good quality of life in those patients who are diagnosed with blood cancers.
Excellent. Thank you so much. And how has immunotherapy changed the landscape of blood cancer treatment?
It had a great impact, actually, in the treatment of those blood cancers. With the advent of immunotherapies, I can say that in any kind of blood cancer, the expected overall survival has doubled at least. But in some specific scenarios, they had a great impact, which induced a cure chance even in some cumbersome types of blood cancers. Actually, it's for sure they have a great impact in the treatment of those disorders like lymphomas, myelomas, and leukemias. I can just give an example from acute leukemias. Regarding Philadelphia positive acute lymphoblastic leukemia, unfortunately, the expected 5-year overall survival was just 15%. It means that if you are diagnosing 100 patients with Philadelphia chromosome positive acute lymphoblastic leukemia, at the 5th year, only 15 could manage to survive. But with the advent of these immunotherapies like blinatumomab or inotuzumab, and also the tyrosine kinase inhibitors, it's just rised up to 60 to 70%. This is a great achievement which was brought by those immunotherapies.
I understand. And can we talk about living with blood disorders and cancers? What are the long-term effects of blood disorders and cancers?
Sure. Actually, we are now trying to cure any kind of blood disorder or blood cancer. If we are not able to cure those specific blood cancers, we are trying to induce a good, healthy, long enough survival. With the help of those non-chemotherapeutic therapeutic advance, we are just able to manage this target, and we are just achieving a good, healthy, prolonged survival. Regarding long-term effects, actually, if you are obtaining a good cure or a good response, nowadays, those patients are just experiencing a good enough health and a good enough quality of life, even comparable to healthy person. That's our main target. And nowadays, we are just managing to obtain that target with the advent of those treatments, which are non-chemotherapeutic treatments.
Okay. And how can patients manage their quality of life during and after treatment?
Actually, we are just advising them to be enough social. I don't want to isolate from any social environment of my patients. I just try to do my best in order to keep them away from infections. If I can manage to keep them away from infections, I am not forbidding any kind of social environment or social activity. And with saying that, I can advise all the patients who are diagnosed with blood cancers to be on a good and healthy diet. It should be a Mediterranean diet. And I am not even forbidding those healthy foods, any kind of healthy foods in patients who are diagnosed with these blood cancers. And also, I'm advising them to exercise. Actually, exercising is a good thing for a healthy person, but besides for the patients who are diagnosed with blood cancers. With that, I'm trying to do my best in order to keep them on track, not keep them isolated.
Okay, and what support systems are available for patients and their families?
Actually, it depends on the facility they're just being treated in. In our facility, we are just trying to keep the family members also in treatment decisions, and also trying them to support the patient. And also we have some psychologists, we have dietitians, we have a good group of healthcare workers who are just involved in the care of those patients. With the help of that kind of group work, we are just trying to do our best in order to support them psychologically, physically, and also regarding the side effects of the treatment to decrease or to keep them away from those unwanted side effects of the treatments.
Professor, thank you so much for your thorough explanation and answering all of our questions. So now I would like to ask you if you have any questions. I think Professor would answer them also.
Sure, I'd be glad if you have any kind of questions, and I'll be much more pleasure to answer those.
Please, if you have any kind of questions, you can just write them, and we're going to read it out, and the professor will answer them.
I think we have covered all the issues, and
yes, I think your explanation was really good, and we really covered all of the questions that were in mind. So if no one has any questions, we would like to end this webinar. Professor, thank you so much. It was really nice to hear your opinion and your knowledge and experience. Thank you.
I'm really glad. Thank you. I'm just glad to have those participants with us, and I will be much more happy to be on some face-to-face meetings in the future, hopefully.
Thank you again.
Thank you.
I think we have a question, just a second.
Actually, there is a question regarding a patient who was diagnosed with a brain tumor, but then it was an involvement of a hematological disorder. Actually, in hematological malignancies like leukemias, lymphomas, and up to some extent in plasma cell disorders like multiple myeloma, we could even have, we are not calling them as metastasis because metastasis is a thing that we can just use in solid organ malignancies, but we call that as CNS involvement, central nervous system involvement, even at the time of diagnosis, but mainly I can say that 90% of the patients develop that CNS involvement after the relapses. That's why if we prevent relapses, we can also prevent CNS involvement. And also we have some primary CNS lymphomas, which are just diagnosed as a sole lesion at the brain and nothing else throughout the body. And also we are just managing to cure all of those patients with the advent of those novel targeted agents like ibrutinib to some extent, and methotrexate or cytarabine integrated chemotherapies, and also hematopoietic stem cell transplantation. For sure, we have CNS involvement in hematological disorders and malignancies. It should be primary. It means that it's just a disease of CNS, like CNS lymphomas, but it should be secondary to any kind of hematological malignancies. In order to prevent those secondary CNS involvements, we have to manage to cure the disease and the track, and we have to prevent those relapses. I hope I should cover that question.
Yeah, thank you so much. Okay then, and for those who would like to listen the webinar in Turkish, we will have a stream at 5. So that's it. Okay, we have just one more question. What are the key considerations in managing patients with blood disorders or blood cancers over the long term?
Actually, regarding long-term effects of blood disorders and blood cancers, we have to induce a good quality of life. In order to manage that, we have to work with patients and family members in order to keep patients really healthy. Health means not only the physical health, it means that both psychological and physical health. In order to induce that, the first thing that you have to do is to take care of the disease with the most advanced ways of treatment. If you treat the patient well enough, and if you can obtain a cure, for sure that patient will have a good and higher quality of life. If you cannot manage that with the use of, actually I can say non-chemo approach, you can also induce a good quality of life in patients who are diagnosed with blood cancers. The patients who are surviving from blood cancers, like myeloma, lymphoma, and leukemia, we can just divide the path to 2. The ones who have not received hematopoietic stem cell transplantation and the ones who have received hematopoietic stem cell transplantation. But the common feature is for sure a lifelong good care of a hematologist with that patient. Regarding hematopoietic stem cell transplantation, we have a lot of even problems, long-term problems like chronic graft versus host disease or some other issues related with infections in the prolonged periods of hematopoietic stem cell transplantation that we have to take care also. Regarding chronic graft versus host disease, nowadays we are using even some targeted agents like ruxolitinib or ibrutinib in order to induce a good remission, you have to take care of those. Actually, the last thing I can just emphasize or underline is a good relation between patient, the doctor, and the family members. If you can just manage to keep all of these relations in a healthy way, it also has a good impact on the health of that particular patient.
Thank you so much. I think we do not have further questions. Okay, so I would like to remind again for those who would like to listen the questions and the answers of our professor in Turkish. We will see you at 5.
Have a good rest of the day. Thank you.